Hello and welcome to this video on developing useful skills for virtual diabetes consultations. On behalf of SBK Healthcare, we do hope that you find it useful. Please do share your thoughts in the comment sections and make sure that you like and subscribe so that you don't miss any new content that we upload. Good afternoon, everyone. My name's Hope Frost, and on behalf of SBK Healthcare, I'm delighted to welcome you to this webinar on developing useful skills for virtual diabetes consultations. Thank you very much for joining us, and we do hope that you enjoy the webinar. I would like to thank Abbott for kindly sponsoring the webinar, and it is now my pleasure to introduce your webinar host, Sue. Hi, Sue.
Hi Hope, thank you so much, and it's great to see so many people joining, developing, and here's Cathe as well joined us, so it's a great pleasure to introduce Cathe to talk through this next session. Now Cathe has got a great background in nursing, has been director of nursing amongst many other positions, but is also now spending her time discussing with health organisations about getting the best out of them. And what I loved in her biography is that, you know, this is all based around language, and language, we have language matters in diabetes, and it has been a real something very close to my heart about, and not just how we speak to other professionals, our colleagues, but also with our patients. And the language that we use can have such a big impact. So moving forward into this virtual world that we are all now working in, trying to get the best out of remote consultations, I think this is the perfect time. So without further ado, I'm going to hand over to Cathe to deliver this presentation, and then we will both be there to answer questions at the end. So please do, throughout this, send your questions through, and then I can organise them, and we can discuss them at the end. So thank you, Cathe.
Thanks, Sue. That was a great welcome. I'm just going to share my screen now and bring up my slides. Thanks for the lovely welcome by Sue. And just to say, yes, my background is nursing, but I'm really interested in language, and particularly culture and how we affect and can cause conflict at times through language, and what we need to do to get things right. And I'm really excited about talking to you about virtual skills, because that's what I'm doing at the moment. All my training is now virtually delivered via video, and I just want to share with you some evidence-based work around virtual skills, but also some of the stuff I've learned through sort of lived experience. So I'm going to take you on to the first slide, really just to give you the context of the webinar. And I don't know if any of you were on the webinar last week where I talked overall about remote working, but I just wanted to set the context that this webinar is particularly relevant in times of COVID, because so much of what we do has changed. So I put the background and the context up there just to give you that explanation. It's particularly around your patients, because we know that COVID has a distinct impact on them. You've got increased patient risks. But also one of the bottom points is that remote consultations are very suitable for patients with diabetes, but also they're very likely to increase. So I'm going to talk a bit more about that as we move on. I've got some learning outcomes, but before I do that, I want to give you all a question, a little factoid. So you've been working with your patients. I'm really interested for you to tell me, what is the way that you think patients prefer to be consulted? Do you think they prefer face-to-face? Do they prefer video consultation? Do they prefer phone or messaging? Could I get some answers coming through in the chat box? I'm really interested to hear from you what your patients prefer, pre-COVID, post-COVID. What do they prefer? How do they like to be communicated? Because it's really important we understand that. How do they prefer? They like you to video call them, or they like you to face-to-face? Can I get some answers coming through Q&A? Be brave, put something in the chat box so I can see. What is it your patients prefer? What is it your patients prefer? Let me take you back there. Everyone's been very quiet. The reason I asked you that question is, really interestingly, patients actually find video consultations quite difficult. And pre-COVID, about 1% of all telemedicine was done by video consultation. So a really tiny percent. Patients prefer face-to-face, and then they like phone consultation. Now, During COVID, that's increased, but it's only doubled. So we're still only sitting at around 2%. Really interesting that our patients find video consultations difficult. And we're maybe going to talk a little bit about that. Is there anything we could do to change that? Why is it that it's not that comfortable for patients? So learning outcomes, I want to talk about creating the right space for you, the workspace, because that's really key. Then talking about rapport and skills needed, because there are distinct skills needed in video consulting. And then I want to talk about patient concerns, and then I want to talk about difficult conversations. Now, a little bit of this was covered in my last session about difficult conversations, but it comes up such a lot. I really just want to refresh the skills and just talk you through how do we have these conversations which are difficult, which don't put our patients off, which need to be said, but help them get to a place where their health is of paramount interest. So I'm going to move through, right. So as I said, you're important. You're important in a video consultation. You're delivering care through a video consultation or eliciting information. One of the things that's really key is claiming your space. Now, a lot of people remote working are either in an office or they're at home. And when this first started out about 6 months ago, we all thought this was going to be a short-term plan. And so people would set up temporary offices. And what we've learned from that is that patients at times have said, video consultations, I could see other people's notes, I could see equipment in the background, I could see stethoscopes, urine pots. It really put people off. So thinking about when you claim your space and you're having your video consult, first of all, make sure you're in a comfortable chair. Make sure that you've got lighting, but the background for your patients should be clear. We've also done some evidence, and patients don't like to see stuff about us. Strangely, they don't like the crowded bookshelf, pictures of the kids. They actually like a clear space so that they're focusing on you during the video consult. And that's an evidence base of research. So really think about, where am I when I'm having my consultation, where I'm delivering it? Noise control as much as possible. And that refillable water bottle. Video consults are exhausting. Anybody who thinks that they're time savers is wrong. They take at least as long as a face-to-face. And actually you could be talking more because you're trying to elicit information. So make sure that you've got water. Background environment simple, and check your equipment. And that's one of the things that happens. Things don't always work the way that you hope they will. So just bear that in mind. Claim your space. Have a consistent place where you're doing your video consults. The temporary time of temporary spaces is gone. We've heard the Prime Minister talk today. Things are moving. People are moving back to working from home. It may be like this for 6 months. So this is the time to think, where am I working? Am I comfortable? Does it work for me? Is it good for me to see my patients in? Right. So people that worked in the field of diabetes, you are ahead of the game, because remote consultations have always been quite high in your world. They're quite high in the world of mental health, but also patients with diabetes. And there's some reasons for that, because of the convenience. So evidence tells us that it's been useful for older patients finding travel difficult, younger patients. They have better adherence if they can fit it around university and school life. Again, it's been very useful for people who have got limited English, who may need a translator, and mothers postpartum with diabetes. So evidence tells us that you're already using this technology well. What I want to talk about today are the soft skills to enhance it. And really, why am I focusing on soft skills? And I'm going to give you another piece of evidence here. There was a toolkit recently published by NHS England called Using Online Consultations, and it had a toolkit about best practice. And one of the top principles is focus on people, not technology. So it's all about what skills have I got that are going to make people feel comfortable when they see me on a video, not in the same room as me, that I can elicit information and build that rapport. So you already would be pretty used to using remote technology. You've already been rocketed through it in the last 6 months. Let's talk about now ways to make it even better. So using a video consult doesn't work for everybody. So evidence is, if the patient's highly confused, particularly we're thinking about people with diabetes, if the patient's highly confused, If they're highly anxious and unable to use technology, which does happen, or if there are intimate areas involved, it's best practice to try and move to another form of technology, preferably face-to-face, and to have a low threshold. If your patient was confused or anxious, possibly due to impact of their diabetes, it's definitely worth lowering the threshold and trying to get them in for a face-to-face. But it is a useful technology, but not in every situation. And then pitfalls of consultation. This is one where I'm really interested in what you might think. Pitfalls, what can go wrong? So you can have that time lag quality, so you can't actually see and hear at the same time of what people are saying. Inability to read expressions. What do you think about that? I'm going to go back again to the Q&A. What do you think about that? Has anybody experienced that when they're using video? Is that a difficulty? Anybody found that? Because for a number of people, actually being in the same room and being able to read the expression is really important. And some people say they can hear the expression better on a phone consultation. They can actually hear the person better. They can maybe even hear the emotion in their voice. They're not concentrating on their face. So really important to think about the expression on people's face. Is it matching what I'm saying? Also, one of the downfalls of video consultations is we can't multitask, because the patient can see us. And this comes up time and time again when I'm talking to patients. I deal a lot with complaints, or I might be talking to relatives, and their experience is I wasn't heard because the nurse was taking notes, or the doctor left the room, or somebody answered a bleep. The multitasking that we take for granted in health can read to a patient, I'm not interested in you, or you're too busy. So it's really important that the stuff that we do every day, our cues, our normal work life, to take notes, that we check it out with the person on the video. I'm just taking notes, that's why I'm looking away. I'm just checking this on my phone, I'm not scrolling on my phone. All those little explanations, the person can see you and they may be reading it in a different way than intention. And also, unexpected interruptions. Now, that's going to happen when we're working from home, or even in an office, it's going to happen. But to someone on a video consultation, when someone walks in the room and you look away, it can be very disruptive to the experience. So again, there are pitfalls to video consultations. Things to think about beforehand. What can I do to address this? If I know I've got a new consult, what can I do to make sure the quality of it is as good as I can get? Right, okay. I'm just going to have a drink here. As I said, you need to keep refreshed when you're on video. One of the things that's helpful, and I have to remind myself, when I'm having a video consult with staff, to actually check who's in the room. Do you actually check at the start of the consultation who's in the room? You may think you're just talking to the patient, but you may have other people in the room. And also for yourself, you can have someone else in the room. So it's really important for video consult. Best practices, you actually start at the beginning of the consultation saying, can I just check who's in the room? It's really important. Now, there may be people there for translation purposes, but it's important that we just check around confidentiality who's in the room. I've got some simple stuff in here, again, coming from evidence base about details and documenting. And that sometimes people have skipped a step in a video consult in that they already have the patient history and they've skipped a step, assumed it was okay or things hadn't changed, and missed deterioration. So again, details and document of the patient, are they still accurate? Now, I've experienced this myself, so I'm shielding, have been shielding, and would get calls and have video consultations, and nobody would actually check my history. They would just take it as read, move on, and this is the next point. Explain your role and purpose. So even though I might be expecting a call, I'd still like to know what's the purpose of the call. And again, because we're in our health mode, you can just move straight into the discussion of health without saying what the purpose of the call is. Is it an initial consultation? Is it a follow-up? Has there been a deterioration? Why are you calling? And the purpose of the session. And that just gives that little bit of control back to the patient. And myself, I know I felt that. I didn't have any real understanding of why I was being called, what the purpose was, and what we were going to get out of it. Empathy, we're going to talk about that in the video. People want to see empathy in your face. They want to see your facial expression, that you're listening, nodding, smiling. And then the last one is about safety netting. So it's really important that safety netting is looked at, because safety netting is something that is only in 60% of audits that I can see. So people say safety netting is the management plan for when something goes wrong. So for me, safety netting would be to be assured I know what to do if something has gone wrong with my asthma. And one of the things that I'm sort of encouraging people to do in video consultations is actually get people to get the patient to repeat what the safety netting is. So as I said, a recent survey, it's only been done 60% of the time. It's a key factor in keeping people well. Try and get that safety netting in. Make sure people know what to do if things go wrong. So again, soft skills needed. That's my thing. I like talking about soft skills because we've got brilliant technology. We've got so much good technology going on in the NHS. But if it doesn't make me feel like I'm listened to or important or special, no matter how good the technology is, the soft skills that we have as healthcare staff are really, really key. And communication in a digital age, it's completely different. So it is slowing down, listening, being aware of facial contact, being aware of not multitasking. All those things are key. And so often we're so busy, we can miss those little cues. So just a gentle reminder that in the digital age, facial expression and tone of voice and slowing down. So I know I need to speak more slowly when I'm on video to people, just so people can take it and process it and think about it. Right, here we go. I've got something on active listening and matching facial expressions. So again, I have found the chat box, and thank you, people are putting stuff in here. What I wanted just to get you to get you to think about is when you look at those people, let me take that off because I might be blocking your screen. When you look at that picture, I have a picture up there of 3 or 4 very attractive models. What do you think their facial expressions are saying? We're going to make an assumption. What do you think they're saying? Are they angry? Are they happy? Are they bemused? Are they smiling? Facial expressions are very individual and we can get it wrong. But facial expressions in a video consult are really important, really important. So this is what I'm going to take you through. When you're doing any one-to-one work, we've got the 60-40 rule on eye contact, because it's okay not to be staring intently at the patient. In fact, people would feel uncomfortable if it's 100% of the time. So you've got the 60-40 rule where people can look away, and you would have said to your person, I'm actually going to take some notes now. So I've got agreement, I feel I'm listened to. But it's really important, if you feel the facial expression isn't matching what they're saying, that you ask what's going on. Because if someone's got a very stern look on their face, or you perceive it as stern and you don't know what's going on, they may not be understanding you, there may be confusion, they might feel angry. It's really important. The facial expression has got to match what I'm saying. So if a patient's saying, yeah, I'm really happy with that, but actually their face is frozen, they're looking really tense, their breathing's labored, you've got to check that out. And that's part of active listening. You're looking at matching facial expressions to what I'm saying. Giving space to speak. And I think I talked about this at the last session if you guys logged on, which is we're really good at problem solving in the NHS. We're very good. We're caregivers. Listening is sometimes really hard because you're on a time pressure and you're conscious you've got other things to do. But in a video, listening, and I'm only talking about 2 minutes. 2 minutes is an optimal listening time without questions. And gosh, that's not very long, but 2 minutes is the optimal time, giving space to speak. The other thing that's really important is paraphrasing. So just checking in with the person that you've understood what they said. So I always, if I'm talking to someone who's very distressed, I'll say, may I stop you? Can I just check this out? And I'll go through what they've told me. I very carefully go through and just check, have I understood you? Now, instantly that builds rapport because they think she's listened to me, but also it helps me understand, I think I got this right. I think I got this right. And that builds rapport. People like to be understood. Summarising is really good if you want to close the conversation down. So you've had a consult, you want to close it down, you summarise it. Agreeing and confirmation, and also avoiding microaggressions. So we're going to talk a little bit about the microaggressions that might just stop people opening up to you. And again, I'm so fascinated by only 1% of people use video consults. Are we doing anything maybe that's slowing this number down? Why do people feel uncomfortable with it? Right, here is check your body language. These are called microaggressions. You might have heard of them, we all do them, but they're the little behaviours that we do that appear as if we're not interested. And we're humans, so of course we're going to do these behaviours. But yawning, of course everyone's going to yawn, but yawning. Watch checking is the classic one. I can be sitting with someone for an hour, have a very detailed conversation, and the second I check my watch, the person's seen, and what they've read into it is that I'm bored or I'm not listening. So these microaggressions are things that cause disharmony between us. Very important on video consults. So I always have a clock over here than on a video consult. Scrolling on your phone. This one we just do all the time. And scrolling on your phone, I think now it's even listed as incivility by the RCN. They've even listed it for nurses as incivility because people are in training or in a meeting and they're scrolling on their phone. It's a microaggression. It makes me feel like you're not hearing me, you're not listening. Answering a call, getting up from the screen, badly positioned screen. Show your arms. So people show a lot of emotion through their arms. Check the body language. Body language is key in building rapport in video consults. So it's all about trying to make the person feel relaxed. You've got that neutral background, you're being interested, you're being engaged, and you're thinking about your body language. I'm not doing anything to put the person off. I'm showing my intention, which is I'm interested in you. I want to hear about your story. I think hopefully I like those pictures as well. I think it's a good one. Right, now coming to some of the difficult stuff in the video consultations. And that is having difficult conversations. Now, we have to have difficult conversations in all walks of life, sometimes with colleagues. It could be difficult things need to be said, honest things need to be said. But with patients, it's quite a tricky thing to get right because I always use this frame, you want to shape the conversation, not shame me. And it's really easy to get wrong because sometimes we get disappointed with patients or we feel they haven't followed instructions or they haven't told us the whole story, which is a common one because if we're not adhering to treatment regime, it's very difficult to tell your healthcare provider. So people will be covert about information that is important. But one of the things that we do, which can put people off, is we can shame them by using words like, this is disappointing, or, this isn't going to help you. When we put anything accusatory, because we're human, into the conversation, it shuts it down. And one of the things that's been really helpful for me, trying to move difficult conversations forward, is using these future-focused questions. So it's future-focused, it's Socratic questioning, it's talking about what would a good day look like? Going forwards, what do you think you could do differently? Tell me about when something went well. So we're trying to put the control back in with the patient, not make them get off the call feeling ashamed. I think we've all had calls with a health provider where we've come off and felt worse than we went on. I often have people call me and say, I don't want to go back. I don't want to go back to that doctor or that nurse or that receptionist because how they made me feel. So the way we have a difficult conversation is key in keeping the relationship going. So if I'm going to have a difficult conversation, usually with staff, I plan the content because speaking spontaneously isn't always a good idea. I plan the content. What do I want to get across? I'm clear on my intentions. I don't want to shame people or embarrass them, but I might have to tell them some honest truths. I'm aware that hearing bad news, whether you're a patient or a member of staff, is difficult. It's really difficult, it's painful, it makes me feel embarrassed, and when I'm embarrassed, I'm defensive. I want to try and shape behaviour, not shame, because I know that when people are shamed, they run away, they leave, they disconnect from service, they move away. And I want to use future focused questions so that we can work together on building something better. And you would even have a difficult conversation maybe about, how did you find the video consult? Did it work for you? What was helpful? What could I do differently? What could we do differently? How can we move it forward so that next time it's more successful? So it's trying to work in that, bring out the adult, put away the parent role, and start talking to people in a way that they are going to come back and be involved in the video consult, not back away. And then lastly, before we go to questions, I put some additional reading up here for you. There is some really good stuff out there about video consults. As I say, it's an emerging and growing field. It's still quite new, even though it's been around for a while. It's not something we use a lot. Brené Brown is a really good researcher. He talks about shame versus guilt. Great stuff when we're dealing with patients. How do we manage that? And there's also some stuff on active listening. So thanks very much. I'm going to get Sue back online. Hi, Sue.
I'm back. Oh, Cathe, thank you so much. And you know, there was so much in there that so resonates, because like everybody else on this call, 6 months ago, I was thrust into this world of, and I'm quite technologically challenged, as my son will attest to. So it's been a great learning for all of us, and there have been some real key messages in the middle of that. Now, looking at the panel of people, I recognise loads of names on that list, and I know you've got loads of experience. So even if you haven't got questions coming in, because we've got nothing yet, just type in and just share your experiences, because this is so key for all of us. We've got one question in first, so I'll go to that from Joe.
Okay.
Then I'll, talk about some of the things that I really picked up from that. So Joe's asking, how can you prepare a patient for a difficult conversation? You stated you would prepare if you were having the conversation, but the patient doesn't get that chance.
Yes, that's true. That's true. Because I think it would scare people if you said we're going to have a really difficult conversation. So one of the things that I do is I control my emotion, because we know emotion leaks. So if I'm very anxious, the patient will be very anxious. If I feel very angry, they'll feel very angry. You're quite right. We can't prepare someone, but how we deliver it is key. So I can manage my emotions so I don't come across too much of a parent in the conversation. My emotions will leak to the patient. So talking about myself, thinking ahead, what do I want to achieve out of this? What's the plan? What's the aim is really important. And you're quite right. I can't control how the patient will experience it, but there's a much better chance they'll experience it positively if I'm looking to change or shape their behaviour, not shame them.
And I think all of that about the shaming is so key. And also going right back to one of the questions, you had the picture of the models.
Yes, yeah.
From the chat comments that came through when you asked, what do you see? This is what really struck me. People were coming back saying they look challenging, they look judgmental, bored, angry, intense. And then somebody put they look neutral. And it just shows how we all see things so differently.
Yeah.
And if we're seeing that, what I've always found in my whole career is what patients hear from us is very, very different than maybe what we intended to say or intended for them to hear.
No, that's a really good point. And that's sometimes what we intend is to be helpful, but it lands really badly. So I often talk about intent and impact. So I might say something like, Sue, in a stern voice, Sue, I think it would be really helpful if you called me 15 minutes later. Now, my intention is to be helpful. The impact is, whoa. Intent and impact often get mixed up, and often staff will say, but my intention was to be helpful, to say this is what you need to do, but the impact was I felt ashamed. So intent and impact are really important. And that's why thinking about having a difficult conversation, what do you want to get out of it? Is your intention to change patient behavior, to help improve adherence? And will the impact likely feel like a telling off? What can you do to change it to get the intent you want?
Yeah, totally agree. Now we've got loads of things coming in now, so I'm just going to run through those before I come. Somebody put in, hi, most of my clinics are telephone, not video. Any specific suggestions for telephone consultation? Now, I think when you started as well, you said actually, and do you know what, because I use a video consult, but there's only one group of the patients that I see who really like it. Everybody else just wants phone call or face-to-face. So amazing that you came back with that as well. So what about telephone in particular?
So I'm doing telephone next week because yes, okay. that is telephone is the after face-to-face, patients want telephone. And again, there's some really good tips that I've taken from Samaritans and other people who are specialists in listening. But what I would say about telephone conversations, you've got a much shorter window to build rapport because I can't see your face. So if you were smiling but spoke to me sternly, you can lose a telephone consult more quickly than a video. Yeah. So evidence is that telephone consults are more popular with patients, but they're actually tougher to get rapport. Because I can't see you. I can't see if you're making a joke. So things, for example, on a telephone consult, sometimes humor doesn't land because people think, oh, I've made a joke, and you can tell I'm joking, Sue, I'm smiling. You can't see that. You can't see that on a telephone consult.
And do you know one thing that happened to me really recently, because I did it, and it was a new patient, so I'd never met them before, they'd never met me, and the consultation was a bit, it was difficult, but it was going okay. And then the next time I spoke to them, they were completely different, and they actually said, and it was like, oh, because it made me really reflect a bit. They said, I went away and Googled you. Yeah. And it's like, my God, this is the world that we're in. Yeah. This is the world that we're in. So I'd spoken to him. I was an absolute nobody, phoning him up to run through his diabetes, and then he went away and Googled me, which is his right to do, I suppose. So that's very interesting, and it did make me think an awful lot, because I think that goes back to the introducing yourself and and setting that up from the start. It's really quite interesting. So
I'm interested, Sue, why do you think, and why does the audience think that our patients are not taking up video, even during COVID? Why is it not growing?
Yeah, I mean, the group of patients who it's worked incredibly well for me is in antenatal care. So I run an antenatal clinic, and those people absolutely took to it, loved it, and I learned so much so quickly, and a lot about balance of power. And I think that links in with another question that's come in. Because the consultation, it really shifts that balance of power if somebody's in their own home holding a consultation. And it taught me an awful lot about record keeping, asking them to write down what was said on their antenatal record, because that's the legal document. So it taught me so much. Yeah. But in every other field that I deal with, people don't want to. And we're really trying to change the way we offer it, make it a bit more assertive, that this is what is it. Just really, really struggling in those areas. But Sue Nightingale's come in here and say, how can you bring a consultation to an end if it becomes out of control, or the focus changes and just becomes a moaning session?
Yeah. Oh, that's brilliant. No, that does happen a lot. So that's where the summarising comes in. Because summarising, you're not actually opening up any other questions. You're pulling together the themes and winding it down. So when you summarize, you take control back. So I am conscious that some people, we moan in a cycle. So when we moan, I tell the story and I go round and round and round. And when I get to the end and I think you're losing interest, Sue, I'll start again and I'll tell you the story, and our patients can do that circular. What you've got to do is intervene when you've heard that story and say, that sounds really difficult. That sounds like it was really hard for you. I'm just going to quickly summarize what you've told me, and we'll finish the call. You need to take the control back, because if you leave me when I'm in my moaning cycle, I could tell you 10 times. You get stuck in the cycle. Yeah. So it's a good point to actually say to the patient, to be honest, say, right, I'm going to summarize now, just so I've really understood. It does sound like it was really difficult. Summarize, which isn't opening any more questions up. You're just laying out what you think you've heard, and then bring it to a close. Because do you know what? Telling my story twice adds no benefit to the clinician. It doesn't actually help.
No, but actually, you can build up and frustrate.
Yeah.
I mean, you can see people do it. If they don't feel listened to, it just perpetuates, doesn't it? It becomes more and more. So Stacey's just put here, using near-me consultations, which I think is a platform for video consults. I know the one we use is Attend Anywhere, which is an NHS one, for patients, and then team meetings, because I think that, again, there's a skill within teams. You can use Skype, virtual clinic, Zoom, and I know there have been a lot of challenges, because somebody came in with a comment earlier that, you know, in their trust they don't like video consult, and that's because I think early on we had a lot of problems with the platforms and whether they were really secure. So there are just a few that are signed off by the NHS for use.
That's true. I think, though, after the Prime Minister's announced we're probably going to be in a 6-month holding pattern and probably less people will be going out, I would say that video consults logically are likely to increase. Yeah. Because this isn't a sprint, it's a marathon, and we've got a 6-month remit now. He's told us that probably the things that have been decided today, if everybody heard, you know, that it's not a lockdown, but things are, you know, at a difficult stage. I would say that patients who are vulnerable, and patients with diabetes are less likely to be going out. So yes, your phone consults will go up, but it makes sense that video consults will go up as well, because in the video consult, you can also see the colour of the, you know, the respiratory. There's a lot of physical information given in a video consult.
I also feel as well, and certainly from the first lockdown, and my big worry for people is the impact on mental health. And if you're at home, and sometimes just having that video consult, just to see somebody else and to feel like you're speaking to somebody that's in the room, I think is massive. And if this is going to be another long haul, I think we really need to think about that.
Now, Jackie's put in a really good question. Is it okay to inform the patient of the time limit? Yes, Jackie, it is. It's really healthy, because it's realistic. You haven't got hours and hours. It also almost sets some parameters around, some boundaries around. It is okay. It's quite hard because it feels quite assertive, but I have to do that if I'm doing a staff consultation. I'll say we've got half an hour. If that's not enough, we can book another time. But it also allows us to concentrate on the key issues. And that's why I like to say, this is what the session is about now. This is what we're going to cover. Is that okay? And keep to the time frame.
Because it's the same as if you were running a clinic.
Yes.
You know, like you said at the start, these are not quicker and easier things to do. So you do have to protect that time. I also like where you said, you know, just double check who is there, who you're speaking to, because again, that's a big concern of mine, you know, just around protecting people. And so when we invite people to do a video consult, we sort of say to them, you know, that this is a clinical session, because, you know, we have had it before where we've joined people and they've been on the phone in the street, and you know, so again, all of that has to be thought about. And I think, you know, this is just an area that we're moving into that we all need to learn and set those ground rules for. So there's a few more comments coming in. Claire's asked, can you explain your shaping of the consultation with an example?
Trying to say, so if it's somebody's talking about, so I'm late, so I booked the consultation and I'm late, and you come on, so you're late, Sue, and I say, thanks, Sue, late, you know, so there's sarcasm there. Okay, and also remember, humour doesn't travel well. So people will say, "What are you? So are you working on Australian time?" No, I thought we agreed to. So again, humour doesn't travel well. Particularly our patients, they can be very sensitive. What we say as a health worker can carry a lot of weight. What would be a shaping comment about timekeeping? Is if someone's late on a video call, I say, "Oh, was it? Just tell me about your day. How's your day been?" Because remember, everybody knows when they're late. And what you do by saying, Sue, how was your day? You say, oh, Cathe, I had the most terrible day. You won't believe it. You know, something happened just outside. I was here. I'm so sorry. This won't happen again. So by using the open question of tell me what happened, tell me a bit about it, rather than going into, which we often do when people are late. Staff are late. Staff hate it when they're late to a conference and someone goes, well, what time do you call this? You know, coming in again, half day. Actually, we laugh, but we feel really embarrassed.
Oh, yeah. Absolutely, yeah. And it's like you say, none of us like being late or intend to be late. And we're late because, you know, life, something has stopped us being there. So it's really, really important. So yeah, we've still got comments coming in. Almost all of our patients prefer telephone consults. So your next webinar is going to be very important. And I think that is true. And there's a comment from Marion. People use social media to hide. Some like the anonymity. I don't know if that's my comment about being Googled. I hate social media. I was horrified. That but it was just, it just shows you the world that we're in. I think it really made me feel, okay, this is, you know, it's what now.
It's fairly normal. If I'm doing an investigation, I'll often find the patient will say, I've checked you're still on the NMC register, I've looked you up, you know what, that's okay if that's what they want to do. I think what this reminds us is it's very important to keep our social media locked. So if you're on Facebook, make sure as any nurse or any teacher, don't go on with your name because patients will check you out. So please, if you're on any social media and you don't want to be seen, use a different name. A lot of teachers use their first name and their middle name, not their surname. So just be aware that our patients are tech savvy and they'll Google us, they'll look at our registration, they will do all of that. It's part of the world social media world we live in. So it's important for practitioners always to think about, can I be accessed on social media?
Yeah, really, really, really good point. So we've got to cover that. So Sue's come in with, you use Microaggressions. I don't know if I've pronounced that right at all. So you can send a text message to the patient prior to their appointment so they can be ready, especially, and again, I think, and that's especially if you want glucose or blood pressure readings so that they can then take those. Really, really useful. Anything that you can do to prepare for that. Yeah. And then also, do you feel taking written notes or typing up on templates, which is acceptable? To me, it's about what has been agreed, and certainly what I try and do, and keeping my hands down and making sure that I'm faced like this, is I can scribble away here without looking away from the screen. So I can be scribbling notes, but you wouldn't know that I'm here making notes.
Yeah. I think, again, it's about boundaries. So if you say, we've got 20 minutes together, the purpose of the session is, and I'm going to take notes if that's okay with you, that's fine. It's when we come in and we still forget to say what our name is, we don't say the purpose of the session, and all you can see is the top of someone's head. And I've had consults, so that's all I could see, the top of someone's head. And I'm like, I can't see, because we're used to doing it our way. And it's just remembering the video consult could be in someone's home. So they're in their lounge. Yeah, they're in their lounge. So if you're talking to someone's home, they want that. You need almost the social norms. If I was going to visit a patient, I would say, my name is Cathe, this is why I'm here. You need to do that in the video consult. So it feels more like an invitation into their world. Now, when they come to the clinic, they're in your world. When you video consult, we're in their world.
And you know, that links so well into the next one, because there's so many points there. And again, when in the days when we could do home visits, you know, that's one thing. If you walk into the lounge and the TV's blaring and nobody turns it off, you set those boundaries. Yeah. But Stacey's come in to say, is there a way to try and focus a consultation if there's chaos happening in the patient's house, children, dogs, visitors interrupting? It can be difficult. And you know, this is when I said about as you're arranging this, to make somebody realize this is a consultation. So you're sort of setting those boundaries before you start, because it is hopeless. If I walked into somebody's home, I would try and deal with that before I did anything, and I would do the same on a video consult.
But if a video consult, if you can't get the information because of the distractions and the noise, it also might be ended early and say, I think we need to rebook this, because you need to get accurate information. So particularly if you think somebody's relapsing in their health, So particularly within mental health, that also might be a sign of they weren't cognitively functioning as well as they should. So I'm always really interested why consults don't work. What's going on? Was the patient not able to concentrate because of the noise? Is that going on in their family? It is okay, I think, to stop consultations if people are getting aggressive, or if you're not getting the right information. It may be that where possible, have a low threshold for a face-to-face, particularly if you feel there's a deterioration in condition.
And deterioration in condition, and the other thing that I'm really interested in is about domestic abuse. And again, you may ask who else is in the room, you don't know. And again, to me, it may be one of the clues. If somebody is constantly distracted or trying to make noise, they don't want you to say something if maybe somebody else is listening.
Yeah, and if you get those clues, try and get a face-to-face, try and get them out. Because again, if people, for example, they're saying that rashes are not particularly good on video consultation. So I know dermatologists are preferring to see it in real time, because they said it's really difficult to make a clinical decision on, the cameras aren't always good enough to do that. So again, if you feel I can't make the right decision, clinical decision, because the information may not be clear, try and move to a face-to-face consultation where possible.
Try and do something to answer that question. No, somebody else has just come in to say again that their patients prefer phone calls, but their worry, so Jane's worry, is that she's worried that her patients may feel that care has been simplified, and therefore the patients may not be taking the self-management seriously, and then the fallout from COVID, and of course now we know the COVID. And I certainly have felt patients seem to fall into two categories here. So people who are a bit disengaged or don't want to know, some of them, because of the media attention around diabetes and poor control of diabetes, have suddenly thought, whoa, now's the time I need to do something, and maybe they've had more time to do something. But other people, it again, that mental health, I've had people who just say, do you know what, I've got so many of the comorbidities, I can't do this anymore.
And I think the evidence is out. So I've read for diabetes that treatment adherence has improved for some people and decreased for other people. It's really interesting. As you said, some people are saying, I'm overwhelmed, I've got a lot of other problems, but younger people are saying, wow, I need to take this seriously. So there's been a real shift in treatment adherence, has not flatlined. For some people it's really improved, for other people it's not. How do we pick up those vulnerable people where it hasn't? Particularly because after today, this is going on a lot longer. The other thing I think that's good about video consults is you can see your patients, and I can't really lie to you, Sue, if I'm in the big black eye here, or I've put on a lot of weight. So again, sometimes video consults, avoiding them, maybe our patients are worried about what we will see. So my aim is to encourage people to mix it up. Some phone, some video, because you get more of a balanced view of what my life is really like.
Yeah, and on the terms of that, the other thing that really struck me, that we found, and some of this about engagement, there has been a massive increase in the use of continuous glucose monitoring and flash glucose monitoring. Now, for us as healthcare professionals in this time where we can't see people, for me to be able to review that data remotely has been a godsend. However, there's no hiding in continuous glucose monitoring. So, we've all dealt with for years, patients maybe not filling in. The people who forget to bring their monitoring diary to a clinic, forget that it's because they hate being judged by those numbers. Now with access to continuous glucose monitoring results, there is no hiding. So before a consultation, I don't even look at it before the consultation, and in the consultation I ask permission to go and look at their data, and then again always try and start with a positive note in it, because I think that's really, really key before we lose people from that glucose monitoring world.
No, you're on the money there, because you know what, people know when they're not filling it in, they know when they're not adhering to it. It's almost by opening the question of how do you think this could work better between, what would a good day look like? Because people know when they've messed up, and what we don't want is to hear it from someone else, because actually we know we've messed up. It's a human thing. I know I've messed up. What I want you is to help me get out of the mess I got into.
Yeah, totally agree. Goodness, well, I think we have no further questions, but there are still some comments. And so Sarah's coming to say, but there are still those who come up with excuses why they haven't downloaded. And do you know what? To me, Sarah, I totally get that, but that to me speaks volumes. If somebody hasn't downloaded their data, it speaks volumes to me. So it's about going, I'm having to go back and move beyond that to rebuild that consultation.
Yeah.
And to rebuild that relationship as to why they don't want to share it. We will always get that, but they've got to be able to talk about the challenges that they're having.
Yeah.
So Sue's come in to say, I had a consultation with a patient who had an A1C 20% and heart failure. When I phoned, he sounded really unwell and short of breath. He appeared to be very laid back. I advised he call an ambulance, but he said his son would take him to A&E. I even phoned later and spoke to him in A&E as I thought he wasn't taking me seriously. Thankfully he did and is now on the mend. I worry that if I hadn't rechecked and he hadn't gone to A&E.
Yeah.
Gosh, that's a real challenge, isn't it?
It is. And that's where that safety netting comes in, and making a note that you've told the person, if your condition deteriorates or it doesn't sound that you're well, this is what you need to do. And when we record that, awful as it is, we've covered ourselves to some extent, because, you know, when people are stressed, they don't always hear. That's why it's really important to get patients to repeat back what's been agreed. When we're stressed, they don't hear. I hear part of it, I'm thinking about something else. Get them to repeat back the safety net. So if this deteriorates, if the next few hours you feel worse, we have agreed you will. Get them to repeat that back, but document it, because safety netting is the way of protecting ourselves, but also people's memory after an incident. You know, I was never told, no one told me.
No one told me. A good friend always told me, who does a lot of this as well, she always said, document like a barrister.
Yeah.
And it's true, you have to not just write, but give some reason to your thinking at the time that advice was taken. And when it comes to, you know, I find as well, we don't want to alarm people, but if you, like in that situation, if you phone up and you think somebody is seriously unwell, you have to be able to impart that so that they register, this is really important and I need to do something about it now. And there's that real fine line between getting the language right, of not scaring people, but
also covering ourselves as clinicians, that we have given advice in best interests with the clinical knowledge we have to an adult who isn't cognitively impaired, who can choose not to take it. But we have to record that, because so many people after the incident will tell me, do you know what, Kath? I think, you know, no one told me. I do a lot of investigations, and 50% of patients believe nobody told them. Luckily, the notes will often say they were told, but also they haven't got a copy of it. So unfortunately, we have to think ahead and almost future-proof. I've documented my clinical decision and advice.
And you know, in the diabetes world, we are all incredibly used to that when it comes to driving advice and the DVLA advice if somebody is on a hypo-inducing agent. We have spent so long having to really document, and people have gone to quite extreme lengths making patients sign that they have been given a leaflet, because we all know, I mean, that's one of the biggest fears if somebody has an accident driving, and they say, nobody ever told me I was at risk.
Yes.
So, you know, I think we're very used to that, but it actually now comes in so many more areas of
in video consultation. So you'll be used to it, and you'll be documenting it in a face-to-face. Do the same level of checks as you would in a video consultation. That's why video consultations, you have to have a break at the end, because you do need to write up and agree what you've done. It's as important to keep your notes on the video consultation as it is if we were having a face-to-face.
And it's quite funny. I went into antenatal clinic one day, and the person said, "Oh, it's okay. You got a great morning. It's all video consults." And it's like, That's not a great morning. That's even more challenging this morning because
Yeah.
it takes so much longer.
Yeah.
And you really...
Because on the phone you can multitask. You can actually make notes and check things. On the phone you can actually get more done. The video, you've got one thing to do, which is to have that video consult. Video consults take longer. I think they could be more intense than a face-to-face because you're taking a while to process the emotions. They are not time-saving. They might reduce infection risk because people don't have to go out, but they are not time-saving. I think some people have mistaken them for, you know, we could do more video consults. No, you can't. They're not faster than a face-to-face.
And the other thing,
yeah.
The other thing from it that I found, because in the antenatal clinic, people would come in with their handheld record, and clearly over the years, I have just followed certain cues throughout the consultation. I fill in this, I ask about this. Suddenly in a video consult, I haven't got those handheld records. Yeah. And I found after the first few, it's like, I didn't even know what dose of insulin.
Yeah. Yeah.
You know, and so very quickly we were learning about how to record, what to go through, checklists,
yeah.
Until it becomes a new familiar habit.
Yep. And Claire has put a brilliant statement down there. Follow up with a care plan, emailed or posted with agreed plan I found helpful. That's so right. We've got to protect ourselves around video consultations as we would in phone calls, as we would in face-to-face. Any time we're transmitting clinical information, we are potentially at risk of it being misinterpreted, lost. It's important that, you know, always think CQC says if you didn't write it down, it didn't happen.
Didn't happen. And the one thing following on from that, Claire, that I do is I also, whilst we're doing it, I encourage the person to write down, right, so we have agreed, if you just write it down so that you know that we agreed on this date, and certainly in antenatal clinic, and found that, you know, they actually followed that plan far better than when I wrote it in, because again, that's the psychological impact. They're writing their own plan.
Yeah, yeah, right.
So, okay, so I think we are, wow, we have timed that to perfection. Thank you so much for all your comments coming through and for staying with us and asking the questions.
Really appreciate it. Thank you, everyone.
Thank you both so much. That was a wonderful presentation and a really, really insightful Q&A session. So thank you both. Just before we end, I would like to say thank you very much to Abbott for sponsoring this webinar. So thank you both very much.